Here we are at Lab 1, which is going to be about diagnostic motion evaluation. This is Deb Getz again, and my contact information is for email, physicaltherapy@hotmail.com, or via phone at 646-221-5293. Please don't hesitate to contact me should you have any questions or concerns about the material covered in this lesson or any of the other lessons that we will be performing throughout this on-live seminar. As a review, diagnostic motion evaluation tells the therapist the exact location of the dysfunction. Where is the dysfunction occurring in our patient that's causing an inhibition of movement or pain or an inability to perform an activity? Tweaking it down will determine whether it is a structural or anatomical dysfunction, meaning something is blocking the motion, or a non-structural dysfunction by comparing the quality of active and passive range of motion. The therapist will utilize her senses during the activity by observing the fluidity of motion, looking for compensations. From a tactile standpoint, she will determine whether or not the motion is being restricted or is difficult to perform. There's a resistance in her palpation. And lastly, communication with our patient to ask the patient at what point in the motion does the activity become painful or difficult or awkward to perform. Principles of diagnostic motion evaluation: when we're going to begin our evaluation, be it visual, tactile, or verbal, if the motion is an open chain motion, meaning that the distal segment, such as a hand or a foot, moves about a fixed proximal segment, such as a trunk or a pelvis, we are going to begin observing at the most distal joint that shares the muscle attachment for the action being performed. Most actions of the upper extremity occur in the open chain. Again, the hand is the distal segment moving about the trunk, which is a fixed proximal segment. In the lower chain, and in the example below, you could look at heel strike, which is an open chain dorsiflexion. And with this activity, we would begin our observation and palpation at the toes. For closed chain motions, our observation and other evaluations for diagnostic motion evaluation principles will occur proximal to distal. And closed chain activities are just the opposite of open chain activities. It's when motion at the proximal segment, like the trunk or the pelvis, moves about a fixed distal segment, like the hand or the foot. Most of the activities of daily living that occur in the lower quadrant, such as walking and squatting, are closed chain activities. So for the majority of those types of evaluations, we will begin our observation at the most proximal joint that shares the muscle attachment for the action being performed. Through our observation, we're going to notice when a motion lacks fluidity. Again, if it's in the open chain, we begin our observation distally. And if it's the closed chain, we begin our observation proximally. We need to think about the row of dominoes. Okay, so we want to look at the most distal segment, if it's the open chain activity, moving before the next proximal segment, and proximal and proximal and proximal, from the beginning of where the motion initiates until the end. And it's important to note that the movement should not only be sequential, but fluid, equally distributed, so that the forces are being attenuated through the entire limb during the activity that's going to be performed. We're going to be moving on now to examples of non-fluid motion. These are videos taken of patients where we're going to be able to see a lack of fluid motion during the activity. For this patient, this individual presents with an externally rotated foot, and that is really a compensation for a lack of rotation in his femur. So at this point, I am going to be moving his femur passively into external rotation and noticing the fluidity of motion. He is in non-weight bearing at this point, so this is an open chain activity. And the muscles that share the attachment for hip external rotation attach most distally, just distal to the knee. So we'll begin our observation down by the kneecap, and we're going to focus on movement occurring at just below the kneecap, through the lower thigh, mid-thigh, upper thigh. So let's watch and see what happens in this patient. I'm pointing out where we should be observing. We're going to focus in, and I'll take my hands and bring in external rotation. And if you notice, the beginning of the motion starts right around the distal 1/3 of the thigh. There is no movement occurring in the kneecap and really through this area. All of the motion is coming in through here. Now, because I am performing passive range of motion, this is going to be a structural dysfunction. At this point, I will now palpate around the structures of this area of the thigh to feel for a structural dysfunction, a restriction in tissue, a hard end feel. Our next example is an evaluation that we call foot clocks, and foot clocks are used to evaluate pronation and supination in the closed chain. As I've just mentioned, this is going to be a closed chain activity. The motion is going to be occurring at the foot and the ankle, theoretically, and the muscles that share this motion that begin most proximally, just proximal to the knee. So our observation is going to begin at the knee, go down through the leg, in through the ankle, down through the midfoot, and to the toes. So when we observe the right lower extremity, this lower extremity right here, I want you to take a look at the motion through the leg and through the foot. And as you're observing, you're going to notice that there is no motion below the ankle on this foot going into supination. Let's watch. All of the motion occurring at the ankles, actually even noting some of the wrinkles. I had mentioned earlier that wrinkles occur with hypermobility. And as we see with pronation and supination, there is literally no movement of the midfoot or the toes during this activity. All of the motion is occurring at the ankle. And it's interesting to note she looks to have swollen ankles here. And again, inflammation is often caused by hypermobility. The second part of the diagnostic motion evaluation principle that we're going to look at and observe is going to be when the range of motion, at what point the range of motion becomes compensated for. And again, looking at this individual right here, his compensation is shoulder elevation and also winging of the scapula, premature motion of the scapula. And when we're doing diagnostic motion evaluation, and if we were doing diagnostic motion evaluation on this patient, this is an open chain motion. The motion is shoulder flexion, and the muscles that share the action of shoulder flexion that occur most distally, just distal to the elbow. So that is where we would begin our observation. And if I was evaluating this patient, I would place my hand on his upper trap and have him bring his arm into shoulder flexion. And at the point where I felt his trap move, I would note at what point in the range that was occurring. And beginning from my observation distal to the elbow to the shoulder, note the point at which the shoulder begins to elevate. So let's see an example of compensation for range of motion. Our next patient is going to be performing AB and adduction of his left leg. And we're going to focus more on the adduction component of this activity. And the adduction should occur in the frontal plane. And while we'll need to clear the pelvis and the other foot to bring the leg across in the front, we should note that there should not be motion occurring at the pelvis or certainly the lumbar spine. And let's take a look at what happens to this patient when he brings his leg into adduction. As he comes across, you'll note rotation. And the rotation occurs right here at the pelvis and the lower lumbar spine. And it looks that the motion begins to stop right around where the stain is in his pants. So let's watch one more time as we look into AB and adduction. Right at this location, look at all of that rotation that's occurring in his lower lumbar spine. And it's no coincidence to note that this individual suffered a herniated disc fairly recently at L4 and L5. The next example is compensation occurring with hip extension. And literally, almost every human being on the planet will compensate for a lack of hip extension. In younger individuals, it typically occurs, the compensation is an extension of the lumbar spine or increase in lumbar lordosis. And in older individuals or those with back pathology, it tends to be trunk flexion. Now, this individual happens to have the herniated disc at L4 and L5, so his compensation is going to be trunk flexion. So let's look here at what's going on in the trunk as this individual brings his leg back into hip extension. Notice he initiates and brings his rib cage pretty much right at about L2 forward. Now we need to note at what point does that occur in the range, and I would say right about there. So fairly early in the range of motion does he start to compensate with trunk movement. This is open chain activity. The motion begins just distal to the knee. And when a compensation occurs relatively soon in the range of motion for the hip extension, if it is structural, and we don't know because this is not active passive range of motion, the dysfunction is occurring right around here. So for this individual, this very well may be a non-structural dysfunction because a non-structural dysfunction can be caused by inflammation. And since this individual has a herniated disc at L4 and L5, he's got plenty of inflammation going on at the lower lumbar spine. And remember, we need stability in order to have mobility. So there's a good chance that he is lacking quality range of motion because of a lack of stability, not because of a structural dysfunction. And this concludes Lab 1.